When you like us to start. All right.
I'm ready when you
Good.
are. I'm going to turn my audio off until you introduce me.
Sounds good. Good morning, everyone. Welcome to TeleShadowing. I'm honored to introduce our mentor and also my mentor and guest speaker, Dr. Cloeren. Dr. Cloeren is an associate professor of medicine at the University of Maryland School of Medicine, where she has been a dedicated faculty member since 2017. She brings with her a wealth of experience in both clinical practice and academic education, which really makes her an exemplary role model for aspiring medical professionals like us. Dr. Cloeren actually earned her MD from the Temple University School of Medicine. She also honed her expertise with internal medicine residency at Hopkins and also receiving her Master of Public Health during her occupational medicine residency at the Johns Hopkins School of Hygiene and Public Health. And in her clinical practice, Dr. Cloeren really focuses on complex return to work cases, pain-related work disabilities, and fitness for duty evaluations. She also dedicates herself to shaping the future of medicine by mentoring residents from institutions such as the University of Maryland, Johns Hopkins, and the Uniformed Services University of the Health Sciences. Dr. Cloeren has also even developed a unique 100-hour elective in occupational and environmental medicine for preclinical students. And this is really a testament to her passion for education and also innovation. And beyond the classroom, Dr. Cloeren's research really explores critical topics such as opioid use disorder, prolonged work disability, and physician-patient communication. And her leadership has earned her numerous awards, including the ACOEM Meritorious Service Award and Outstanding Coach Award from Thread. And today, Dr. Cloeren will really share her career journey. I know I give a few spoilers, but Dr. Cloeren is going to really elaborate on all that and the invaluable lessons that she's really learned along the way. And we're incredibly fortunate to learn from someone with her expertise and dedication to both medicine and education. So please join me in giving a warm welcome to Dr. Cloeren. Thank you so much.
Thank you very much for the very nice introduction. Um, so, what I'm going to talk about today is you can tell from the color of my hair that I've been around for a while. And my whole career really has been in occupational medicine. Even though I trained in internal medicine, I was on the path to occupational medicine, and that was always my goal. So let me tell you about that. Slides to advance. There we go. So what is occupational medicine? If you've been in some of the other sessions that we've done this month, you might already have an idea. But a lot of people have never heard of it, and many people confuse us with occupational therapy, which is a fine field, but it's not a medical field. It's a therapy field. Ours is actually a specialty that has board certification through the American Board of Preventive Medicine. And traditionally, occupational medicine might have been considered, you may have thought of it, if you thought of it at all, as maybe industrial medicine, industrial health, thinking about things like asbestos harming the lungs or lead poisoning, diseases of workers. And that's still a very large part of occupational medicine. But I like to think of it as a two-sided equation because quite a lot of what occupational medicine physicians do is work on the question of how is a person's health problem impacting their ability to work? What can we do to help this person with a health problem work effectively? So things like reasonable accommodations and fitness for work, return to work after injuries, things like that, all are also topics in occupational medicine. So it's occupational and environmental medicine. So you may be wondering about the E. When I was a baby doctor, the E was basically what have we done to the environment that is hurting humans? So things like pollution and toxic chemicals in the water, that may hurt humans, and that's still a very large part of the E in occupational and environmental medicine. You're probably aware of um, forever chemicals and microplastics and all the concerns about them. So that's a large part of what occupational medicine training is about. And some people kind of, with my specialty, kind of focus on the environment. And of course, as we know, humans have also had an effect on the environment. And our training as a population health kind of specialty prepares us pretty uniquely, I think, to help solve some of the problems around climate change and weather disasters. So, as I said before, it's a preventive medicine specialty. There is board certification. It's through the American Board of Preventive Medicine. Most of the docs that are actually practicing taking care of workers are not board certified in the specialty. They may have gotten training in another specialty and then just kind of wind up caring for workers. The specialty training programs only have a few slots per year. There are not very many of them. And it's weird, it's got a different funding stream for residency than most of the clinical residency programs. It's not through the Centers for Medicare and Medicaid Services. And I think as part of the reason that it's been kind of a little bit hard to find. We're a very well kept secret, and I appreciate the opportunity to make us less secret here. There are insider tips at this website, and tells you all about kind of the different pathways and the ways to become board certified, where to find the residencies, how the residencies work. Because in your programs, when you're a medical student, you may not find anybody in your medical school that would be able to help you. So you may have to find some other mentors and use some of these resources. So these are the 10 occupational and environmental medicine competencies according to the American College of Occupational and Environmental Medicine. And we'll go through them kind of one by one, give you a little bit of an example of what we're talking about here. So clinical, somebody gets hurt on the job, taking care of somebody that is injured on the job or maybe has allergies to something that they're working with. Taking care of a population of workers and the clinical illness related to that. Occupational environmental medicine laws and regulations, the classic example of that is OSHA, the Occupational Safety and Health Administration. There are other kind of regulatory agencies. There are other laws that we need to know about, like the Americans with Disabilities Act, Family Medical Leave Act. A lot of the regulations that deal with taking care of workers have to do with human resources kind of issues and the rights of workers. And so in occupational medicine, you learn a fair amount about that. And we often interact with human resources and legal people, in a workplace. Environmental health, I covered that pretty well. Work fitness and disability management. Questions like, how to help somebody with a disability function at work. What kind of accommodations does someone need? But also things like somebody with a specific health problem. Are they able to work? Can somebody with a specific health problem function as a firefighter, for example, or get back to work right at, driving a truck after a heart attack? Examples of that. Toxicology is part of our training. We need to understand the impact of different chemicals that workers may come in contact with, how they get into the person, what the toxic effects are, how to protect the person from it. Dealing with a case right now of somebody that works in a laboratory and is handling a chemical that can get through the gloves that the person's using pretty quickly. And how do we let her do the job that requires a lot of dexterity and protect her from the chemicals that can get through the particular gloves that are available. So that kind of question comes up. Hazard recognition, evaluation, and control. So we have to be able to look at the work that someone is doing, the work area, the ventilation, and kind of noise, things like that. Recognize when something is hazardous and work with industrial hygiene and safety personnel to keep the workplace safer, but also to identify people that may be at risk so that they can be monitored. We've got a large and now growing role in disaster preparation and emergency management, things like explosions. The World Trade Center collapse many years ago. Occupational medicine physicians are still dealing with the aftermath of that. Occupational medicine physicians are helping with fitness and just the effects of wildfire smoke on the firefighters that are taking care of fires, is an example of that. Health and productivity. We need to understand kind of the basics about, cholesterol and diabetes and smoking. And many of us are in situations where we help companies with workplace wellness programs and screening and counseling for healthier life. The COVID-19 pandemic was an opportunity really for occupational medicine to shine. A lot of people that never heard of occupational medicine before were seeking our expertise during the pandemic because we are trained to deal with kind of populations of workers and, fitness for return to work and what kind of protections and, how do we track and contact tracing and all that kind of stuff. So, occupational medicine is a preventive medicine specialty. It's a public health specialty that is also clinical. And then, managing populations of workers. We're in the process of setting up a new occupational health software program and have to think about well, and all that that entails. It's not much fun at all. But it's important to have a good, robust information system so that you can assign people with specific exposures to specific groups so that you can make sure that they have the right vaccines, that they have the right respiratory protection, that they're not being harmed by their work. So these are the competencies. How did I get to this point? One of my influences, that's me several years ago when my hair wasn't gray. And my father, we were at a baseball game. It was a rare occasion where the Phillies from Philadelphia, which is where I came from, were playing against Baltimore Orioles. So you can see I'm wearing an Orioles hat and my dad's wearing a Phillies stuff. So we're not in the same league, so they hardly ever play against each other, but they were at that time. And so he came down to the city to enjoy a game with me. My dad was a big influence on me in part because of his work. And I had the opportunity in high school in summers to work summer jobs where he worked. And he worked for a company that designed kind of monitoring and measurement equipment for industrial furnaces and that sort of thing. This isn't it, but it looked kind of like this. And if you can imagine me as a high school student wearing sandals and a mini skirt, walking around this area, delivering things to people, like there weren't a whole lot of controls. I found out much later that there was plenty of asbestos there. So I've probably been exposed to asbestos, but it was, and I just sort of seeing people working. I've always been very interested in people at work. I did not decide to go to medical school until after college. I was a little intimidated by pre-med students, and I didn't have any role models in medicine. And so I didn't actually really consider a career in medicine. But right after graduating from college, I found not right after. I was originally a waitress for a while. My parents were like, "Are you going to do this after that college education?" But then I found a job that was working for a company that had a mission that is now obsolete. Shortly, well, a little while after that job, the internet came along. But this was pre-internet, and this was a company that took scientific articles, journals from all over the world, basically, and there was a group of people that had language skills that were translating, the titles and the abstracts so that the abstracts could go into indexing, very kind of similar to what PubMed is today. But it would go into like little kind of like specialty focused thin journals that would be sent out to researchers. And it was called Current Contents. And I had German language skills. In college, I got to spend a year in Germany. My German is not great, but it was good enough to translate written materials. And one of the journals that I was translating, I don't know if it was this one actually, but it was a German occupational medicine magazine. So the medical journals in general, I wasn't all that interested in. But I really got into the articles in this one. I thought, oh, there's actually a specialty. Arbeitsmedizin is actually, work medicine, occupational medicine. So really at the time that I started thinking about maybe I could go to medical school, I was already interested in occupational medicine, which makes me really weird and very unusual because most pre-meds have never heard of it, most medical students have never heard of it. And honestly, most physicians have never heard of occupational medicine. So it was a little bit of an advantage. So, I took some extra courses. I got into Temple University School of Medicine in Philadelphia. I joined AMSA. AMSA is the American Medical Student Association. And that was kind of formational for me. I wound up leading a task force on occupational and environmental medicine with another medical student that was across the country. We wound up doing a residency program together. We're still good friends. He works here in Baltimore. His wife and me and my husband, we get together regularly. But we met actually in medical school, which is interesting because we weren't even at the same medical school. One of the things I did as the one of the chairs of this task force on occupational and environmental medicine, that nobody had heard of, but at our medical school, they heard of it because, we made sure they did. This picture to the right is a screenshot from a movie. I remember hosting kind of movie events for medical students. And this one was called Song of the Canary. If you get the slides, there's actually a link to the movie in it. You can find the movie on YouTube. And it was just an interesting movie about kind of using workers as the canaries. The story of canary in a coal mine, where birds, if the birds died, then you might want to get the workers out soon. These guys didn't have canaries; they were the canaries. And so it was kind of an eye-opening movie about hazards to workers and how workers are often considered kind of disposable. My mentors, I went to Temple University in Philadelphia. There wasn't anybody in my medical school that had heard of occupational medicine. I was actually a little bit dissuaded at the time from going into occupational medicine. I remember my preceptor in medical school saying, well, if you're going to do internal medicine, you really need to do an organ subspecialty. And I'm like, no, that's not what I want to do. But anyhow, I found Rosie Sokas, who was at the University of Pennsylvania at the time. She's now been at Georgetown University for many years on the faculty in occupational medicine. She's a lovely, wonderful person who takes care. One of her interests is migrant farm workers and the health of migrant farm workers, people that are working in the gig economy. She was the medical director for the Occupational Safety and Health Administration at one point. When I was working with her, so as a medical student, I got to just collaborate with her, across town. Um, she got us to meetings of something called Philipposh, which I don't think is still around anymore, but it was the Philadelphia Area Project on Occupational Safety and Health. There were labor unions there. There were also government people there that had a soft spot for workers and really wanted to do the right thing, but they would have to come in disguise because they weren't allowed to be like officially there because of their government roles. It was a really interesting time. Um, Dr. Melissa McDermott was also in Philadelphia at the time. She's my boss now. She's at the University of Maryland School of Medicine. She also became the medical director for the Occupational Safety and Health Administration. So there were some very powerful occupational medicine influences in Philadelphia when I was a medical student. I got to do my first publication with Dr. Sokas, ironically, on occupational health and clinical training. And our findings were that there isn't much training about occupational health in medical school. And, not much has changed, unfortunately. Um, and one of the things I did with her, this picture is going to come up again. One of the things I did with her is I saw patients with her, and I remember her asking me to go to the library and research a specific condition that she suspected a veteran might have. She did some of her work was at the Veterans Administration, and so you can tell how dated this is. I don't know if any of you recognize what this card file is, but this is totally, no, I don't know. Hopefully everywhere around the world it's obsolete, but this was a library card file system, like the Dewey Decimal System, and you'd have to find like the right drawer that represents, the journals that you want, and then kind of look through by paper. It was a crazy way to try to find articles, but I found the articles and was able to help that veteran. But what I learned there actually is important. That'll come up in a minute. Another very important mentor for me was Dr. Jim Keogh. Jim Keogh is really the reason that I chose Baltimore for my residency. He was, at the time that I chose my residency, at that residency program. By the time I got into the residency, he left and had come to the University of Maryland. I wound up at Hopkins Bayview for internal medicine, and Jim Keogh was across town now at the University of Maryland. But I still got to rotate with him and see patients with him and, write a book chapter with him and just, learn from him. He founded something called the Occupational Health Project, which was dedicated to, a lot of it was workers who were working on doing construction on bridges in the area, and they were removing paint that was lead paint, and many of them were getting lead poisoning. He also identified many cases of asbestosis in workers in the area that were working with asbestos. The occupational health project that he founded eventually became our division of occupational and environmental medicine here at the University of Maryland. He died way too young. He died of cancer in his, I think, oh, around age 50, which was really sad. He never took anything from drug companies. I remember this really vividly about him. So this was during a time period when there were not the controls there are today on pharmaceutical industry influence. Um, but I don't know if anybody remember, I don't know if you know the connection to what I just put up there, but Jiminy Cricket is a character in the movie Pinocchio, and he basically acted as a conscience. You know, he sits on a shoulder. And so like Jim Keogh sits on my shoulder and he was such an ethical person that if I ever have kind of a quandary about what to do in a case, and as you might imagine, sometimes there are ethical kind of issues when you're dealing with workers and also dealing with their employers. Whenever I have an ethical quandary, I think about Jim. What would Jim do? So here's a case I saw with him. And this was so during my residency when I was doing a rotation with him. There was a truck driver who was transporting boxes of chemicals. He came in to see us a week or two after it happened. The boxes were not marked hazardous. He stopped for the night and still driving. It was a long haul trip, and he found that one had tipped and the contents had spilled. So he cleaned it up and didn't take any precautions. He slept in the same clothes, right? And so then he noticed over the next couple of weeks that he started to develop numbness and tingling in his hands and feet, which persisted. It wasn't getting better. He had a workup that was negative for the usual kinds of things you need to think about for damage to the peripheral nerves. He didn't take any medications that could have caused it. His examination and testing showed that he had a peripheral neuropathy, that the nerves in his distal, hands and feet were not working right. So what caused it? So one of the things that we discovered was that the chemical containers inside the box was marked hazardous. So the boxes were not marked hazardous. They were sealed. And inside the box were tubs that were marked hazardous. But there were no safety data sheets available. It was a new chemical that was in research and development, and there was nothing known about the toxicity of it. And you'll find, well, I don't know if you go into this field, you'll find that many chemicals that are out there, we don't have a whole lot of data about the safety. So you have to make some educated guesses based on what they're like. And this particular chemical contains something called acrylamide monomer, which is known to cause the same kind of peripheral neuropathy that he had. So this is a safety data sheet on, so this is on acrylamide, not on the new mixture that he was working with, but on acrylamide itself. And so you can see that it can be absorbed through the skin and it can cause peripheral nervous system, neuropathy, et cetera. So, so his symptoms were very much consistent with that. So what are the implications of this? This was a sentinel event. Okay, so this is somebody that was made sick by a new chemical in research and development. Somebody needs to know about this, right? We want to try to protect other workers. And that's actually one of the important things about occupational medicine. When we identify something that is work-related, especially if it's something novel, it's really important, or something unexpected, it's important that we consider who else might be at risk for that. So this was a sentinel event. The Occupational Safety and Health Administration had to be notified. We helped him with workers' compensation, which is a little bit tricky. Like, how do you prove that it was that, when there's no data actually on that? It also led to me writing a book chapter. Doing some of this work and working with mentors can help you with publications, which is great. So I wrote a book chapter called Acrylamide in a book called Hazardous Materials Toxicology. And so this was a case that kind of illustrates our competency in toxicology, clinical medicine and dealing with the patient, work fitness and disability management, maybe laws and regulations. So in occupational medicine, it's rarely going to be just the clinical situation. There's always going to be other considerations. So here's another case. This is a 46-year-old fisherman. And so this case, so the last case I told you about was one that I saw during my residency. This was a case I saw maybe a couple years after getting out of residency when I was in my very first job. I was doing both internal medicine and occupational medicine. And I was, God knows how, because I was so young, but I wound up kind of in charge of managing a bunch of medical clinics. And one of them was on the eastern shore of Maryland, where there are a whole lot of fishermen. There are a lot of people that work on the water. This guy was worked on the water, and he was a Vietnam vet. And he came into the clinic. And I was visiting one day. It wasn't my home clinic, but I was visiting and helping that day. And he had a recurrent rash on his arms and on his legs, and he had developed a very painful swollen area on his left leg that had been there for several days. And he said that he'd been having this rash for a couple of years. And every time it happens, he goes to the hospital, he goes to the ER, they diagnose him with cellulitis. They admit him or not, but they treat him with antibiotics, and he gets somewhat better, but the rash never really goes away. And it's worse in the summertime, which I think is interesting. Worse in the summer makes you think about something that may be related to heat or sun exposure, right? Something related to differences between summer and winter. He reported that in the past couple of years, he'd noticed a lot of blistering and tearing of his skin, with just minor trauma, and that he also thought that his urine had blood in it. So on exam, this is actually him. He had a bit of a fever and he had an area of cellulitis on his leg. His face was very red. On his hands, arms, and legs, he had vesicles. And vesicles are, if you've ever had poison ivy, that's what a vesicle is. It's a tiny fluid-filled little bump on your skin that can open up. And then small bullae. And bullae are kind of like vesicles, but they're bigger. So more like if you're wearing new shoes and you get a blister on your foot, that's kind of and it fills up with fluid. That's kind of what a bulla looks like. When it's related to disease, it's usually thinner skin than that. But some of the lesions had crusted over, and some of them you could see that some were hypopigmented and some were hyperpigmented, more lighter and darker. And those kind of they go along with things at different ages, different. So some of these are old and healed. You can't see it that well, but this was a bullous lesion that had already kind of popped and was on its way to healing. I think this was another one. So, there was evidence of different ages of them, right? And so the fact that I had looked up, that I had done this work with Dr. Sokas with the card file back at the VA made me remember what it was I'd looked up. And I had a really good idea what was going on with him, which made me feel like a Sherlock Holmes, and which I'm not. But this one was kind of lucky in that I had exposure to, um, the likely diagnosis. So here we are at this little clinic on the eastern shore of Maryland. I'm here with this guy that probably needs to be hospitalized because he does have cellulitis too, but he also needs a workup for this disease. And so I called, and this was this would have been early, maybe 90s, early 90s, I think. So I called the doc that was working with me, who was on call that day, and said, I'm bringing somebody back to the hospital, which you're not really supposed to do. I drove him in my car. Don't tell anybody. I know this is being recorded, but don't tell anybody. And got him there. But I told my colleague what I thought was going on and asked him to gather some materials for us to be able to do some diagnostic tests. And so this is back in the days where you could do some bedside diagnostic tests. So one of the tests, we had him urinate, and his urine is the one on the right. We had a coworker provide a urine sample just for comparisons for a picture. The photography was terrible, but this was the 90s, and it's not digital photography. So you can see that his urine is darker, right? But it did not test positive for blood. It was just darker, which was interesting. Dark blood should make you think of dehydration, but he was not dehydrated. So we did a diagnostic procedure, which was, and I'm sorry about the quality of this picture, it's just, what we had. So on the left is the urine of the control. On the right is his urine, which we acidified. We actually got acid from the lab, and we acidified his urine. And then we used a wood light, which, UV, black light, basically, to on the specimen. And this pink here is fluorescing, basically. So his urine fluoresced, which really confirmed the diagnosis. And I don't know if any of you are smart enough to figure it out, but he wound up, and I got I got a publication in the New England Journal of Medicine. So I was naive and unacademic at the time. I had no idea what a stretch it was to be able to publish in the New England Journal of Medicine, but I got a publication. It was in the Images in Clinical Medicine section. It's just like a little one pager that included these poor resolution pictures and his story. So I have the link there if anybody wants to actually, I don't know if you can see the whole thing. So the diagnosis here was porphyria cutanea tarda. Porphyrins are part of the hemoglobin metabolism. And if there's kind of an interruption in the hemoglobin synthesis pathway, then you can spill porphyrins into your urine, and then they'll fluoresce, with that test. So the connection was porphyria cutanea tarda has been associated with Agent Orange exposure in the Vietnam War. And he was a Vietnam veteran who had Agent Orange exposure. So we were able to connect his service work as a veteran with the condition that he had. And he was able to actually get VA benefits for that. Now, the other problem for this patient is porphyria cutanea tarda is very sun sensitive. And he makes his living as somebody that takes people out on fishing charters. So can he continue to do that work? So that's one of the, does he need vocational rehab? Does he need help finding another job? But making the connection to his veteran experience, helped him get access to benefits that would allow him to get treatment for it, but also help him if he became disabled, unable to work or get vocational rehab. And so this is kind of an example of like the diagnosis is not the answer. Even the treatment is not the answer. In occupational medicine, there's almost always other considerations. So clearly it was clinical here, and making the diagnosis was really important to him. But then we had to also deal with work fitness, disability, his claim, just kind of understanding the toxicology of it. And we would not have been able to make the connection without kind of knowing about the exposure relation. You're recognizing the hazards. Here's another case that also while I was in that job, nobody's going to guess what this is. So this is a plastic bag, just what it looks like. And this is acid fast bacilli, which is a stain for Mycobacterium tuberculosis. And there's no way you're going to guess this, but this is just to set you up for the story. So at this hospital, there was a patient who had been inpatient on a substance use rehabilitation unit about 2 weeks before. He had multiple tuberculosis risk factors, a productive cough. He had not had a workup when he was in the rehabilitation unit, but he showed up this day and got a workup in the emergency room. And with the doc, I'm sorry about this overlapping it. But he was admitted to this hospital with acute tuberculosis, and he was admitted to an isolation room. Now, just before this was circa 1995. The plan was to put him on airborne precautions. A little before that, the National Institute for Occupational Safety and Health had recommended some guidelines to protect healthcare workers for potential exposure to tuberculosis. So we're just starting to pay attention to this. But you worry about somebody with active tuberculosis coughing and affecting not just other patients, but the workers caring for them. So it's important that if you are going to put somebody in an isolation room that is really an isolation room, and it should be a negative pressure isolation room, which means the air should be pulled into the room and then out through dedicated exhaust, right? Preferably through filters. You don't want the air blowing out into the hallway. You want the air controlled so that what he's breathing is not going out into the hospital ward. And the nurses were like, well, yeah, it's an isolation room. It hasn't been used as one for years. We don't remember when maintenance was last year to check on it. We're not really sure. And so the industrial hygienist and I decided to do like a quick and dirty test of the airflow. And so we cut this plastic bag into little strips and knelt down in the hallway outside the room and put the little strips of plastic in the gap between the door and the floor to see whether if it was really negative pressure, the bag strip should be sucked into the room, right? If the airflow has gone that way. And instead, it fluttered out, which told us that the air was flowing out into the hall, and this was not a safe room, um, and so the nurses were able to get quick attention from the maintenance team. So that's kind of a goofy example, but it's a understanding, how ventilation should work and the importance of recognizing the hazard. Um, I want to talk for a minute about another interesting job that I've had. I don't know if any of you have heard of mustard agent. Mustard agent was a chemical weapon that was used in the First and the Second World War, I believe. Definitely in the First World War. This was people that were blinded by it, who were kind of lined up, and they were walking, holding on to each other because they weren't able to see because of the mustard agent effect on their eyes. It was used to basically debilitate people. Enough of a dose could kill you. It can cause respiratory failure, just pulmonary edema, kind of sloughing off of the tissue in the lungs. It's a pretty horrible weapon. And after those wars, chemical weapons were kind of mostly banned. And in our country, we decided that they're not going to use them anymore. But they're still being stored all over the country. And so there was an effort in the 90s and 2000s to get rid of these stores of chemical weapons. And I had the opportunity to work as the medical director of one of the facilities that was getting rid of cans of mustard agent. These were like big, they hadn't been like weaponized, they hadn't been put into missiles or anything like that, but they were these big drums basically of mustard agent. They were corroded and full of full of poison basically. So the workers, there was a facility built that would use hydrolysis to actually neutralize the mustard agent, but to handle it, we had to protect the workers. And so the workers dressed like this. This is not them. This is typical for how they would dress. So they, and actually, this is actually not the best picture because they had self-contained breathing apparatus. What this is showing is a canister respirator which filters the air. The workers for this facility actually were wearing, like firefighters do, a tank of air that delivered clean air to them. You can't rely on this for something very toxic. But the suits were like this, and as you can imagine, if you're doing heavy work in a kind of hot environment, wearing something like this, heat stress is one of the considerations. So they had to do multiple entries into this toxic area, handling these drums and getting them into the equipment for hydrolysis. There's a lot of heat stress. There's a lot of anxiety. That's kind of worrisome work. We had emergency medicine technicians that monitored them consistently, made sure that their heart rate was not going too high, that the respiratory rate was safe, that they were able to speak, that they could say, "Yeah, I'm okay." So heart health was really important, right? And before even suiting up and putting on the equipment, they had to be screened, make sure their blood pressure wasn't too high, and I can't remember the other things that we did for screening, but we did a bunch of things for screening. So this is not actually the drums, but they look kind of like this. What do you think is more dangerous to health? The toxic chemicals in these drums or this kind of food? This is a trick question, but I want it's to illustrate a principle. So this work we had a lot of contract workers come in that were relocated. They were brought in kind of temporarily to do this work. And so they were put up in extended stay hotels where they, weren't cooking for themselves, and maybe may have had like a little kitchenette, but not much in the way of cooking facilities. And so they got vouchers for a local chain restaurant. I'm not going to say the name, that's famous for Southern style cooking, and they ate at these restaurants every day. And this is a restaurant that brings very big helpings and lots of bread. And so what do you think happened to their cardiovascular fitness? These guys, they packed on the pounds. I mean, all of them had increased weight. And so there's the idea of immediately dangerous to life and health, IDLH, which obviously this is, and then kind of more gradually dangerous to life and health. And so in this job, we had to deal with work fitness, being able to put on the suit, making sure that they were adequately protected, understanding the toxicology of this, understanding the ventilation, alarms in case there's um, any escape of it, et cetera. So we had to understand all of that kind of classic occupational health stuff. But we also had to do something about this. And so that's more the health promotion side. And so we started a health promotion program. I wasn't able to get exercise equipment in there, but we were able to do some guidance on cooking, shopping, nutrition, and counseling, smoking cessation, et cetera. So at this job, all these competencies, were addressed. So in my current work, I've been here on the faculty since 2017. This is a sample of what I'm involved in. Occupational medicine, there's just so much variety in what you get to do. One of the things that we are working with is a cohort of veterans from the first Gulf War who were exposed to depleted uranium, and some of them are still carrying fragments of depleted uranium. This is because of friendly fire events where they were in tanks that were made of depleted uranium, and then munitions that were made of depleted uranium could pierce that. And so there's shrapnel basically that has depleted uranium in it. And you think uranium is like, oh gosh, radiation, but depleted uranium is not very radioactive. Uranium, however, is a heavy metal. And so we have to worry about heavy metal toxicity. And so we're following them really, to see if there's a toxicologic effect. And so far, what we're finding is there's probably impact on their bone health, which makes sense because things like lead will also, having high lead levels also decreases your bone health. I am the medical director of a program that follows a group of like 30,000 former construction workers that worked at nuclear plants. We do a lot of research, but also just provide screening exams to help them identify any health effects from that work. Here on campus, we're doing employee health. We have a biosafety, biosafety risks, a lot of lab research going on here. I am doing work on opioid use disorder in the workplace. All those boxes you see behind me are full of naloxone for a project where we're trying to get naloxone into the hands of construction workers because they're dying of opioid overdoses at a much higher rate than others. So while we're working on kind of the root causes of that, we want to try to make sure that all construction workers have naloxone so that they're prepared to reverse an opioid overdose if they encounter somebody with one. And so far, I think we've given out about 8,000 kits. It's a really wonderful project. In cases that I'm involved with, I may be the cases that I like to see most clinically, and I'm not highly clinical, but the cases that I may see often deal with work disability prevention, fitness for work. And I do a lot of teaching, including courses on climate change and doctor-patient communication. This is students that were on a field trip with me. They're in my occupational medicine class, and we were visiting a site that does kind of logistics and some manufacturing. So these are questions that we're trained to answer. Just to give you sort of a sample, if the cases didn't give you enough as a sample. So is this worker healthy enough to enter a toxic area wearing OSHA level A protection? So you have to know what OSHA level A protection is. How should we protect and monitor the health of workers responding to Ebola? What's the right personal protective equipment? How do we get that to them? Especially if we're talking about low and middle income countries. Was this patient's hearing loss caused by her work? Are there other workers at risk? What kind of accommodations could this patient's employer make to help her be able to do her job? When can this pilot return to his job after a heart attack? How do we protect the health of first responders in natural and man-made disasters? This is actually the recent fires, or the current fires in Los Angeles area. How can we screen for risk for poor outcomes in people that are injured on the job? Poor outcomes are not usually related to medical kind of issues. There are a lot of other kind of risk factors that are psychosocial in nature and may involve the system, may involve the worker, may involve the employer. And what can we do with information if we know how to screen to try, what can we do with it to get better outcomes? This truck driver's got sleep apnea and high blood pressure. Can he drive? And I want to just, this is actually an actual patient of mine who gave permission to share, and actually he's online. So I want to just show this little 2-minute video um, about him because this was a really interesting case.
Who can only see out of one eye be allowed to protect and serve?
Yes, is what a 26-year-old man out of Montgomery County is arguing. Fox 5's Stephanie Ramirez has that exclusive story tonight.
Guys, 26-year-old Ryan King says he always wanted to be a Montgomery County police officer growing up in the area. He says he interned with the department and did eventually graduate from the police department's academy in early 2021. But he tells us the past year and a half it's been a fight to be a full-duty officer. Here's why.
It's horrible. It's like a golf ball is behind your eye. And my eye would, water. And so I was just ecstatic that I made it through and did well. So yeah, I was just proud of myself.
That was January 11th, 2021, the day 26-year-old Ryan King graduated from the Montgomery County Police Academy. But you can see in his pictures his eye being pushed out of the socket. King says his medical issue got worse going through the academy, and soon after graduation, he underwent surgery to remove a tumor from behind his right eye.
My optic nerve was getting its blood supply from the tumor, so he removed the tumor, and my optic nerve doesn't get blood supply anymore, so that's why we think I lost vision.
Now looking at a legal battle, the county police union says he is being discriminated against. The 26-year-old says a county contracted doctor inappropriately used guidance from the American College of Occupational and Environmental Medicine, saying monocular vision is a limitation. The county doctor placed restrictions on King, who was then stuck on desk duty, even after at least 4 specialists before and after the county's findings argued he should be reinstated. King says he even tried to show he could do it, going back and scoring 116 out of 120 in target shooting and passing EVOC at night in 61 seconds. That's the emergency vehicle operating course. He had to score under 112.
That's actually where we see a lot of the rookies fail at the academy, is EVOC instructions. What happens if you get sprayed in the face with pepper spray? What happens if I get sprayed in the face with pepper spray? I can't see anything. What happens if someone comes up and chokes me from behind? I can't. Ryan is going to do the same things as anybody else. He has the same danger as anybody else, and he can overcome those just like anybody else can.
Look what's right and wrong, and give me a fair shot.
A doctor says King has 20/15 vision in his left eye. He says he has adjusted. He has peripheral vision, even though not the 180 that we're used to with 2 eyes. He also says he just wants a chance to get through field training so that superiors can determine if he can do the job. Now, because of privacy laws, the county officials cannot legally comment on this case or pending litigation, but we do know arbitration is expected in March. Guys.
Okay. So it's an interesting case, isn't it? He found me and we talked about his case. There was not actually a standard that said you have to have vision in 2 eyes to be able to be a police officer. So there was not like a legal reason to keep him from being able to do it. And so the question became, what's the evidence that he can or can't do it? And there wasn't, there was information from his eye doctors, from kind of a vision, kind of functional therapy group, saying that he could do, that he's adjusted well, and there wasn't anything really that he couldn't do. And then he had the functional kind of test showing that he scored better than probably most of his peers using just one eye in his target practice. And then he was able to maneuver a car quickly around impediments, at night, and, he was driving at night, so there was no functional evidence of inability to do his work. And so my conclusion was that he is able to do his work. And this was an example of where it takes an individualized kind of an assessment, not just kind of a blanket, people have to have this or that. And this is the way, kind of the world, at least in this country, is moving, or was at the time I saw him, that that you do an individualized assessment and make a determination whether somebody's able to do the job or not just kind of blanket rules. And so this was going to go to arbitration. I was going to have to testify in it, and a decision was made to allow him to proceed to what is called field officer training, where he would ride with this is just like it's a normal step in the progression of any trainee before they're fully out in the field, is you ride with an experienced officer who gets to observe how you do, which just seems like a really reasonable way to figure out whether he's going to have any problem or not, like on the job with an experienced person. And he did fine. And this was actually, I think, about 2 years ago. And I still stay in touch with him, and he's doing quite well. So that's the kind of case I love to see. So if you're thinking, what am I going to do? Occupational medicine has many, many different kind of paths that you can take. And I've had many different jobs with it, in my career. And so, if you want to see the world, there are opportunities in occupational medicine in kind of in international companies, or maybe doing international research. Some of my colleagues do that. If you're easily bored, there's just like so much variety. And yeah, as I said, I've changed my mind a lot of times, and there's lots of flexibility to just kind of redesign your path. If you like sleep, it's good to know that most of the jobs in occupational environmental medicine are day shift. There's not call. Burnout, when we're included in surveys, and often we're not because we're kind of buried under preventive medicine, but when we're included in surveys, we've had the highest job satisfaction and the lowest burnout, which is pretty cool. And so I think I can wrap up, and there'll be time for questions. There's a lot of variety. The challenges are diverse. It's way more than medicine. And like it's medicine plus HR plus legal plus communication. It's like knowing a bit of behavioral health is important in it too. There's a strong demand for occupational medicine. The lifestyle's nice, and we tend to know each other because we're such a small group, and we have to share with each other. So anyhow, I'll stop sharing now, and I'd be very happy to take questions.
Perfect. Thank you so much, Dr. Cloeren. I know I learned a lot, and I really enjoyed that you went through so many different aspects of your career. We just have a couple of, clarifying questions, more specific questions that students have asked. So I'll go ahead and start the Q&A session. So our first question is, what does your typical day as an occupational medicine physician look like?
There is none. My typical day is I try to work out my calendar for the day and work in the stuff that I need to work on between the different meetings. Let me tell you about yesterday. That might help. All right. So yesterday, there was a meeting with, we do some consultation for a sister university, and so met with the team there. We had a meeting with the people with whom we work for the construction worker cohort. There was a lot of meetings actually yesterday. There was a meeting with the health department on occupational health surveillance, where we work closely with them. Had journal club with a resident. There's nothing clinical yesterday. I developed a infographic about avian flu for workers that are working with dairy cows and need to know what to do if the cows get sick or if they find a dead bird on the campus. This kind of research work with dairy cows. Working on a paper. I met with a medical student this week about a survey that we're planning to do of our construction worker trainers. I think I mentioned that we trained 100 some construction safety professionals to do naloxone training, and we're planning a research study about stigma among them to try to sort out like kind of at what levels stigma about substance use disorder is most prominent. So, a good bit of my day currently is around teaching and research and employee health kind of stuff. So, spending time implementing this occupational health software program so that we can really roll out the employee health program here. Made some plans to visit the worker that's having problems with chemical breakthrough in gloves, things along those lines.
Yeah, that all sounds great. I know you said that, it changes daily and, weekly, and you never know what could come up. So that's all really interesting that you're able to have such an impact. So you mentioned the role of stigma in wellness. So what are your thoughts on like the role of mental health in workplace wellness?
Um, I think we made a mistake segregating mental health from health. I think most people that have an acute injury or are dealing with chronic kind of health problems have emotional adjustments that um, can benefit from kind of a behavioral approach. But I think we tend, our tendency to kind of label things and the stigma related to those labels can prevent people from getting the help they need. Does that make sense?
Yeah, that makes sense.
I don't have depression. I'm just in pain, that kind of thing.
Exactly. Yeah, we have to prioritize both alongside because, if your mental health is not in shape, then it kind of affects the physical health and vice
Yeah.
versa.
But I
So
think
yeah.
that it's also our system requires us to stick labels on things for billing. It's like, what did you see the person for? And, you can't say, I saw the person because they're having a really hard time adjusting to their new reality after this injury. And you gotta put a diagnosis on it. And I think that's actually one of the problems with our system.
Very true. Yeah, I agree. Because you can't just say like, "Oh, I was hanging out with the patient" because they needed someone to talk to.
Yeah,
You
and
have
which
to
is
label.
totally legit. Sometimes they
Yeah.
do that.
So how do you envision the role of Ahmed evolving in the next 10 to 20 years, and what sort of like challenges that you might come across in the future?
Um, our specialty, because it's one in this country at least, and it's different. We've had similar problems in other countries, although some countries have I think been more successful in promoting it as a specialty. Um, we tend to be small everywhere, but in this country, it's kind of compounded by the different funding streams. And the Ahmed residencies here are mostly funded through the National Institute for Occupational Safety and Health. And so it has to be funded kind of ongoing. It has to be part of the budget. And so it's different than the more clinical specialties. And Ahmed is and can be, a very clinical specialty, and the training includes a lot of clinical experiences. But anyhow, we're not taking care of inpatients. And so the CMS, the Centers for Medicare and Medicaid Services funding does not apply to our residencies. And so that the funding part always makes it a little tenuous. And who knows what's going to happen with government funding. There may be different administrations that have different commitment to worker safety and health, let's just say. So I think it's a little bit hard to say. I do think that there is going to be a pressing need for people with a population health perspective and training, and who really understand environmental health with the climate crisis and with extreme weather events. And I think that our specialty is kind of uniquely, maybe not fully prepared, but what we learn about fits really, really well with what companies and society is going to need to try to mitigate and help us adapt and hopefully prevent worsening.
Yeah, that makes sense. It's hard to predict, but just we can make some sort of light predictions based on our experiences and the technological innovations. But yeah, I guess we should just like stick around and see what happens. Okay, so our next question is so I think recently Ahmed was added to the ERAS portal, which is the electronic residency application service. So can you talk about like how long is the residency in occupational environmental medicine?
Yeah, you can get those questions answered at the AOEC site, and I don't run an occupational medicine residency. It's 2 years to answer, and an MPH is part of it. But there are a few different kind of pathways, so I don't want to kind of commit to that being the whole answer. There is a way to for people if they're boarded in preventive medicine to do some OCMed for a while and then sit for the exam. So there are a few different pathways. There's at least one program that takes docs that are kind of out in practice already and uses their work site with a mentor to give them the experience that they need. And then they go, I think monthly for didactic kind of training. So there are a few creative approaches to OCMed training, but in general, it's 2 years.
Yeah, that makes sense.
But
That's
usually
great.
you have to have a clinical year first.
Got
So
it.
yeah.
Okay. So I know you mentioned, or my sister mentioned in the introduction that you developed a elective for preclinical students. So what was sort of like your motivation for that, and how has that been like?
My motivation for joining the faculty here is I love to teach. So, ever since I came, I was trying to figure out how to get into the teaching into the teaching pathway. Um, I This is a really unique elective. There's nothing really like it in the country. Having access to the students for 100 hours is kind of unheard of. Um, it's the fourth cohort now. I think it was a combination of resourcefulness and creativeness on my part, persistence on my part, and serendipity, because my timing was perfect. This was when the school was revamping its curriculum, and they were moving to a curriculum that was kind of organ system based rather than pathology, pharmacology, et cetera. So the revamping of the curriculum meant they were also revamping the approach to electives. And so it was partly my timing was right. I pitched it at the right time and got some help from the preclinical lead to tweak what I had proposed. I'd originally proposed 40 hours. He goes, well, we can give you an elective, but it's got to be 100 hours. I'm like, what? But it was 100 hours over 2 years. It's a lot of fun. I mapped the content of what I'm teaching to what the students are learning about organ system wise. So when they're learning about blood and host defense, infectious diseases, the content that I'm teaching about is things like infection prevention and control, and preventing tuberculosis in a hospital in a low and middle income country, or dealing with the pandemic here. So try to map what I'm teaching to what they're learning about in their classes. And I think that's worked out nicely. Oh, this is fun. I also have movie nights where a few times over the course, they come to my house for dinner and we watch a movie about occupational environmental medicine topics. And I cook dinner for them. And that's really fun. And then we also have field trips. So
That's great to hear, honestly. And it's great that occupational medicine is getting sort of the spotlight that it deserves so people can be more aware of it as they go into, picking their specialty and stuff. So, I was looking through your research and it was really interesting how it's like so broad in scope. So, do you have any tips for students interested in research like that and like how they can join and get involved?
um, yeah, I mean, there's not a reason why you have to stick with your own institution, I think, first of all. So, especially if you're interested in this specialty, um, you may or not be able to find somebody that is in this specialty at your institution or who is a researcher in what you're interested in. So I think broaden your horizons and look for someone that is doing research in what you're interested in. And I think most of us are very welcoming and would find a way to include you in research projects. I haven't counted it up, but since coming here in 2017, I have involved I would say probably at least 15 students in different publications. Um, so I mean, you have to be a little bit proactive. but I also sometimes you wind up joining a research project just because it's convenient. I don't think you have to do that. I think you can try to find somebody that matches your interests and passions. They may just have to be outside your institution. Um,
Exactly, I agree. No, I know it's research and like publications have sort of just become, academic currency in a way, but
they
it's
are,
important to
yeah.
get involved with what you're interested in and what you actually see yourself, contributing the most to. So
Yep.
it's good to hear.
Oh,
And
another tip: learn how to use like Zotero and other, or another reference manager like early.
exactly,
It's really
got
helpful.
to pick up those skills fast enough.
Yep.
All right, let's see our next question. How do you advocate for systemic changes to improve workplace health on a national or global scale?
Ugh. Well, so globally is a little bit easier to answer, I guess. I'm the chair of the medical education, or the chair of the education committee for the International Occupational Medicine Society Collaborative, which is kind of an umbrella group of OCMED societies around the world. And I think I don't remember how many societies, but I think there are 43 countries that are members of it now. As you may imagine, to have an OCMED society, you have to have training pathways in OCMED. You have to have residency programs. You have to have a way for people to become OCDocs. And so higher income countries are better represented in the IOMSC than lower income countries. And a large part of what IOMSC is trying to do is try to kind of bring up the specialty in low and middle income countries, trying to help establish training pathways, trying to establish opportunities for education. We're planning international global grand rounds in occupational environmental medicine, kind of focused on climate change. I've got grand ideas about a curriculum. I don't know if we'll be able to pull that off. Not this year, probably. Uh, so, working with collaborators, internationally. Um, Nationally, I think the work that we're doing to try to promote the specialty and make people aware of it so that we have occupational medicine specialists in the future. I've been very involved in the groups, working on that.
That's
And
great to
this is
hear.
part of that.
It's awesome that you're so like, involved in so many different aspects just to, because you're so passionate about the specialty. I like how you call them off docs. I'll start using that. Okay, our last question is how do you collaborate with other specialties or healthcare providers like in your practice or in your day-to-day to ensure, comprehensive care?
Yeah, I don't see a lot of patients at present. But so for some examples, the the employee that I was talking about with the possible reaction to chemicals, and the glove issue, we may need to find a dermatologist that's able to do specific kind of testing. Um, there's a pulmonologist that works closely with us in the project. That's actually a member of the team that's following the health of the former construction workers because respiratory conditions are so high in them. Um, I think the way I'm really trying, this is not quite an answer to your question, but what I'm really trying to do is make sure that because there's so few of us and not all of us are taking care of workers every day, right? Day in, day out. And so who's taking care of workers? It's people in other specialties. It's, family medicine, primary care, emergency care, urgent care, orthopedists, neurology. And so a large part of what I'm trying to do is help specialists in other areas understand the basics of what they need to do to take good care of the questions around work that their patients have. Um, and part of that is what we're doing, in the occupational environmental medicine elective for the medical students. My goal is not to make all of them OCMED docs. And they're not, I mean, like if one or two of them are, that hooray, but they should be prepared when they are seeing patients in their clinical years and then after to ask the right questions and to kind of understand a little bit more about workers' compensation and work disability prevention and the impact of inappropriate use of opioids on a person's, long-term stability in the workforce.
Yeah, no, that definitely answered my question. Thank you.
Yeah.
Thank you so much, Dr. Cloeren. Those are all the questions we have for today. I'd love everyone to please give a warm thank you to Dr. Cloeren in the chat box for this awesome and inspiring session.
Thank you. I appreciate the opportunity.
Thank you so much. Now we're going to conduct our closing session with our quiz and future session dates. So the link to the quiz for the session is now live. And again, you'll need a 70% or higher to pass and receive certification. Our next session is actually tomorrow, Saturday, January 25th at 10 a.m. Eastern Standard Time for our last session of Occupational Medicine Month. So thank you so much for attending today's session and all of our OcMed sessions, and we hope to see you in upcoming sessions as well. This concludes this week's shadowing.